Welcome to yet another video tutorial by Synapse. In continuation with the blood malignancy series, topic for today's tutorial is acute lymphoblastic leukemia. Right? So let's begin. That is ALL. Okay, so that is acute lymphoblastic leukemia. Okay, so the nomenclature again, so let's do that. So acute, we already know, refers to the immature cells, right? So increase in the immature cells, those are the blasts. Okay, so lymphoblastic refers to the lymphoid series. Okay, and leukemia means the neoplastic cells are found in the bone marrow spilling into blood. Okay, fine. So in our previous videos, we have studied the myeloid series in detail, right? So there was not much information given about the lymphoid series. So let's just have a look at it. Lymphoid series gives rise to two cells, right? So you have the B cell and the T cell. So immature cells, may it be the myeloid series or the lymphoid series, both develop in the bone marrow. Okay, so let's just see the development of the lymphoid series here. We have the multipotent hematopoietic stem cells, okay, which are in the marrow. Okay, so they will develop into what is called the pro B cell, and this turns into pre B cell. Okay, so rather I would just say that all of this development happens in the bone marrow, and we'll just collectively call these cells as lymphoblasts. Okay, they're the immature cells, right? That's why. Next, what happens? Then this will enter blood. Okay, this was in the bone marrow. Now it is going to enter blood and become what is called mature B cell. Okay, mature B cell. So what happens to this mature B cell? Okay, let's just continue it here. So we have this mature B cell. So 95% of these B cells, okay, will go into the germinal center of the lymph nodes. Okay, that is the active center in the lymph nodes. That's where the proliferation and basically the activation of the B cell will happen. Okay, not proliferation, it is the activation. Then 5% of these cells will go into the mantle zone. Okay, mantle zone of the lymph node. Fine. Now the 95% which go to the germinal center and get activated, out of them they can either turn into what is called as plasma cell, or it can turn into memory B cell. So we know that plasma cells are the ones which produce antibodies. Okay, and memory B cells are the ones which come into play when there is subsequent infection with the same antigen, because these cells will remember those antigens and there will be heightened reaction, immune reaction, when the same antigen enters for the second time. Okay, cool. So now what we'll do is we'll just have a look at the tumors that can arise from here. Okay, see, these are the blasts, so whatever comes from here will be acute. So we have the ALLs from here. Okay, it could, if it is B cell, it is B cell ALL. If it is T cell, it becomes T cell ALL. Simple. Okay, so then we have the mature B cells in the blood. So what are these mature B cells? Basically, mature stands for chronic, so it will cause CLL. It will result in CLL. Fine. So again, these cells in the germinal center, correct? So they can give rise to what is called as the follicular lymphoma. Okay, can cause follicular lymphoma or diffuse large B cell lymphoma, or it can also result in Burkitt's lymphoma. Okay, so germinal center B cells can result in follicular lymphoma or diffuse large B cell lymphoma or Burkitt's lymphoma. Now what happens to this 5% here? So mantle zone, what tumor can arise from here? It is the mantle zone lymphoma. Simple. Mantle zone lymphoma. So from plasma cells we know very well, so we're going to get multiple myeloma. And these memory B cells, okay, they will result in marginal zone lymphoma. So best example for this will be maltomas. Okay, maltomas. Okay, so now what we shall do is we'll just have a look at the risk factors, okay, like we did for other tumors. Okay, before that, the age distribution. So age distribution here, ALL is basically seen in children, just remember that, and the average age is around 13 years. Okay, so that's pretty young. And again, sex predilection, boys more than girls. Okay, so and this differentiation is also important. Between 1 to 9 years, it's commonly the B cell tumors we see, and then more than 10 years, if ALL occurs, it's most of the times T cell type. Okay, fine. So now let's just get into the risk factors. Okay, just to mention, B cell is associated with good prognosis, T cell is associated with bad prognosis relatively. Okay, now risk factors, if you just remember the headings under which we discussed for AML and CML. First we talked about the environmental factors. So here the only thing you need to remember would be about radiation. Radiation is an important risk factor. Next we talked about hematological conditions. Hematological conditions could be acquired or congenital. Here the only thing you need to remember would be regarding the congenital hematological conditions. Okay, if you remember what was told in the AML chapter, we said that the most common leukemia in Downs is ALL, right? So but if AML occurs, it will be M7 type of AML. Okay, so next let's just go into the mutations that you have to remember. Okay, basically the cytogenetics. Okay, cytogenetics. So the most important mutation that is to be remembered in ALL would be translocation 1222. Okay, so it's 1221. I'm sorry about that. How do you remember this? It's just that it's palindromic, it's mirror image. So 1221, and this is associated with good prognosis. Okay, and then this, you have a sense of familiarity here. It is 922. That is nothing but Philadelphia chromosome. So Philadelphia chromosome is characteristically associated with CML. We all know that. And if it is present in CML, that means it is having good prognosis. Apart from that, Philadelphia chromosome can also be seen in cases of ALL if present is associated with bad prognosis. Okay, this is to be remembered. So another translocation is 411. This is also having bad prognosis. Okay, fine. This is regarding the translocation in cytogenetics. One important point regarding your molecular genetics would be you should know what are the mutations occurring here. There are two important mutations. One is the Notch1 mutation. Next one is HOX11 expression. If they are present, then it is again good prognosis. Okay, Notch1 mutation and HOX11 expression. And hyperploidy or hyperdiploidy is associated with good prognosis. If it is hypodiploidy, then it is bad. Okay, the logic is pretty simple. When you say hyperdiploidy, then there is excessive amount of chromosome. More the chromosome or more the DNA, easier it is to target the cell and kill the cell. Okay, the tumor cells, I mean. Fine. So now let's go on to the clinical features. Okay, so what will you remember here? You have to remember a child, okay, because it's common in children, somewhere between the age of 1 to 9 years, okay, complaining or coming with the bone pains, okay, the child has bone pains, and the bones are very tender when you touch, okay, so bone tenderness is present, right? So again, we have to go back to the nomenclature ALL, right? So acute. So acute means immature cells. Immature cells means bone marrow. So what happens is these tumor cells take over the bone marrow. Hence, the patient will have pancytopenia, like our AML, right? So here again, the characteristic feature will be pancytopenia. So child will have anemia, thrombocytopenia, and as well as neutropenia. But then actually what happens is the absolute neutrophil count will remain normal. The total counts will reduce. Okay, I'll write it here. So total count will reduce, but the absolute neutrophil count is maintained or normal. So hence they'll have only minor infections. They won't have life-threatening infections. Okay, then again, there is one concept that is to be remembered. We said ALL, right? Acute meaning marrow, right? So in the marrow, we're having our B cells and T cells. Both develop in the marrow, but B cell will mature in the marrow. Okay. Meanwhile, T cells mature in thymus. Okay. So that is why in 100% B cell ALL, okay, we are going to have the marrow findings. Okay, in 10% of T cell ALL conditions, we see mediastinal mass. Okay, so because of involvement of the thymus in the lymph nodes, so here the child may present with dyspnea. So if you do an X-ray, you will see mediastinal widening. Okay, fine. Then classically, you don't see any organomegaly again because it is acute. We have said it will be limited to the marrow. Exception is again T cell ALL, where you will see lymph node involvement. Okay. Next, these cells, these immature cells, they have a propensity to uh, go away or metastasize to the CNS. Okay, basically the brain and eye, or they can go to the testes. So these are some things that are important to remember in ALL. Okay, they can also go to the pericardium and pleura. So this is something to be remembered. Okay, fine. So again, a list of things that are associated with good prognosis and bad prognosis. Just making a point here. Okay, so what is good, what is bad? So we'll see from the point of presentation. Okay, first age. Okay, good, we said within 1 to 9, less than 1 is bad, more than 10 is bad. So we said type. So B cell is good, T cell is bad. Okay, then one more thing we missed out was about race. So whites have good prognosis and blacks have bad prognosis, correct? And then at the time of presentation, let's say it's already involved the CNS, or it's gone to the testis, or it's gone and involved your mediastinal lymph nodes. Okay, so all of that will go for bad prognosis. And we know here translocation, what was it? 1221 palindromic is good, so bad is 922 and 411. Okay, so molecular genetics, we studied that notch1 mutation is good, along with the HOX11 expression. So these are associated with good prognosis. Fine. Okay. So let's move on to the treatment part. So just before we go to treatment, I'll just mention that we have a classification of ALL is into L1, 2, 3. Okay, so basically what is to be remembered is L1 is having good outcome, L3 is having bad outcome. Okay, L1 is good, L3 is bad. Now let's go on to the treatment part, right? Treatment of ALL. So what we have studied is, for AML, what did you study? Induction remission phase, post remission phase, and the maintenance phase, correct? So the same thing we're going to follow here. So we have induction remission. So what is to be remembered here is this mnemonic VAP. Okay, so where V stands for vincristine, A is L-asparginase, and P is prednisolone. Okay, steroid basically. Okay, so we're going to give this for 4 months. 4 weeks, or rather 1 month. Okay, we're going to give this for 4 weeks. This is what is induction remission. If you have to remember one side effect of each drug, okay, which is pretty important. So vincristine is going to cause SIADH. Okay, then prednisolone, we all know it causes osteoporosis, and L-asparginase is associated with pancreatitis and thrombosis. Okay, pancreatitis and thrombosis. Fine. So after we induce the remission phase, we go on to the post-remission phase. Okay, post-remission phase. So in this, we are going to continue the drugs, the above mentioned drugs, okay, plus a number of other drugs are also going to be added, which is pretty complicated. Let's just keep it simple here. The above mentioned drug with intrathecal methotrexate. This is the crux that you have to remember. Okay, so it is intrathecal methotrexate. Why? If there is, this is given when there is CNS mets. Make sense? Okay. So we finished induction remission. We went into the post-remission phase. Now we got to do the maintenance therapy. Okay, so you're going to do the maintenance therapy. Here again, just continue your methotrexate. And to this we're going to add 6 mercaptopurine. So this is 6 mercaptopurine. Okay, so this we are going to repeat this cycle till we complete 24 to 36 months. Okay, so we're going to finish or repeat these cycles, okay, until we complete 2 to 3 years of treatment. Okay, so just recapitulating whatever we have done regarding ALL. First, you need to understand the nomenclature of the disease. What does acute stand for? You should know the components of the lymphoid series and about the leukemia part. So then we come to the clinical features. Children 1 to 10 years, and regarding the prognosis, okay, it is better in whites compared to blacks. Okay, then important translocations, that is 1221 is good, 411 is bad, 922 is bad, Notch 1 mutation is good, Hox 11 expression is good, and hyperdiploidy is good. Okay, and ALL can metastasize to the CNS, testes, eyes, skin. Okay, it can involve any of these organs. So hence in the post-remission phase, to target that, we are going to give intrathecal methotrexate. Okay, and the major drugs you have to remember during the induction remission phase would be VAP, the mnemonic is VAP, vincristine, L-asparginase, and prednisolone. Side effects of each of the drug is mentioned. And maintenance therapy would be with methotrexate and 6 mercaptopurine. Okay, so in the next video we shall take up CLL and SLL. Thank you.